All right, everyone. Well, welcome to session number 245. Am I a candidate for a non-surgical treatment option? A discussion about percutaneous ethanol ablation and thermal ablation procedures. My name is Jennifer Holkem, and I am a passionate educator and advocate to save the thyroid whenever possible. After my own experience in 2019 with RFA treatment of a large benign thyroid mass, I co-founded Save Your Thyroid, a community and future nonprofit organization for patients seeking FDA-approved non-surgical thyroid-preserving treatment options. Due to a severe lack of patient-oriented resources on this topic, I began creating and sharing educational content on my YouTube, Spotify, and social media channels. Through these efforts, I've had the unique privilege to interview patients and experts from across the globe, seeking to bridge the gap between patients and physicians. I also publish patient-focused resources on Substack and the nonprofit website saveyourthyroid.org, including lists of known physician providers of thyroid-preserving treatment options. I devote a full-time effort to disseminating these free resources to the Save Your Thyroid community and the public at large. I will share links to all of these resources in the chat later on for anyone who wants to take advantage of them. Also, just a reminder, please remember that the information presented in this webinar is for educational purposes only and is in no way a substitute for consulting with a medical professional. Now, I would like to introduce our physician speakers. First, Dr. Ralph Tufano was the Charles W. Cummings, MD, Endowed Professor in the Department of Otolaryngology, Head and Neck Surgery at the Johns Hopkins University School of Medicine from 2012 to 2021. Dr. Tufano served as the department's director of the Division of Head and Neck Endocrine Surgery from 2011 to 2021 as its first director. He also established the American Head and Neck Society Accredited Fellowship of Endocrine Surgery there in 2014. He has served on the board of the American Thyroid Association. He was also instrumental in the establishment of the Surgical Affairs Committee for the ATA and served as its inaugural co-chair. He is a past chair of the American Academy of Otolaryngology's Endocrine Surgery Committee and served on the American Head and Neck Society's Endocrine Section Board. He's authored over 260 peer-reviewed papers and more than 40 textbook chapters related to thyroid and parathyroid diseases. He's also edited 2 textbooks in the field. His research interests include novel-directed therapies for the treatment of thyroid and parathyroid diseases, clinical outcomes, research including transoral thyroid and parathyroid surgery, and determining the value propositions for thyroid and parathyroid surgical care episodes. After 21 years at the Johns Hopkins Medical Institutions, Dr. Tufano joined the Sarasota Memorial Healthcare System in 2021 to direct the First Physicians Group Multidisciplinary Head and Neck Endocrine Center that consists of a dedicated thyroid and parathyroid center and Head and Neck Cancer Center. He is now a clinical professor of surgery at the Florida State University College of Medicine, and Dr. Tufano is a ThyCa medical advisor. Next, we have Dr. Agustin Andrade, who is an interventional thyroidologist at the Thyroid Center in Miami, Florida. Dr. Andrade is a renowned pioneer of radiofrequency ablation of the thyroid and laser ablation of the thyroid with expertise in large thyroid nodules. In the U.S., he is the first physician to perform laser and one of the first 3 physicians to perform RFA in the country. Dr. Andrade is the chief of the division of the endocrinology department at Mount Sinai Medical Center, Miami Beach, Florida, president of the Miami Endocrine Association, clinical assistant professor, Florida International University, Herbert Wertheim College of Medicine, founding member and current secretary for NASOIE, the North American Society of Interventional Endocrinology. He served on the ATA Clinical Affairs Committee and is the U.S. patent owner for the thyroid core biopsy needle and biopsy cannula. He established his private practice at Mount Sinai Medical Center in 1997. In 2009, he became the founder and president of the Thyroid, Parathyroid, and Pituitary Center in Miami. Dr. Andrade is also one of a handful of physicians in the country who performs percutaneous alcohol injection for thyroid cysts and thyroid glossal cysts. And lastly, we have Dr. Giovani Mauri, who works as an interventional radiologist at the European Institute of Oncology in Milan, where his clinical practice is dedicated to image-guided, minimally invasive treatments in oncologic patients. Particularly, he is an expert in thermal ablation of liver, kidney, lung, bone, and of course, thyroid tumors. After winning a research grant in 2013, he published the data of the first clinical experience on the application of laser ablation in the treatment of metastatic lymph nodes in the neck from papillary thyroid carcinoma. Since then, he dedicated his clinical practice and research to the improvement of minimally invasive treatments in thyroid cancer patients. In 2018, he founded the Minimally Invasive Treatment of Thyroid Group, MITT, the first interdisciplinary group of experts focused on research on the topic of thyroid minimally invasive treatments. In the same year, he started the clinical application of thermal ablation as a first-line treatment option for patients with papillary thyroid microcarcinomas, promoting this kind of treatment as an alternative to surgery and active surveillance. Due to his long clinical experience and scientific work, in 2021, he was appointed to lead the European group of experts that produced the first guidelines on thermal ablation in patients with thyroid tumors. He is actually the chairperson of the Cardiovascular and Interventional Society of Europe, (CIRSE) Task Force on Thyroid Thermal Ablation, working at expanding the evidences and education on this topic. And so with all of that, we will start the discussion on ethanol and thermal ablation treatment options for thyroid cancer. So my first question is for Dr. Andrade. Dr. Andrade, will you please give us an overview of ethanol ablation and thermal ablation and what their applications are?
Sure. Well, good afternoon and good evening, Dr. Mauri. It is an honor, it's a pleasure to be here and have the opportunity to inform patients about the non-surgical treatment for thyroid nodular disease. So I will start saying that there is a 60% chances of having thyroid nodular disease at some point in the life of the person. 30% of the nodules are cystic or cystic and solid nodules. There are two kinds of treatment: the thyroid ablation and the percutaneous ethanol ablation. The percutaneous ethanol ablation is intended to be treated to be the treatment for thyroid cyst. In the thyroid cyst, you evacuate the cystic content and you put alcohol. The intention is to cause a sclerosis or scarring, let's say, of the lining of the cyst. In cyst, you can also use the thyroid ablation, where you remove the cyst and then you put up a radiofrequency ablation or a laser, and you cause heat in order to cause coagulation and destruction of the cells. In the solid nodule, though, we don't use alcohol injections. We use a thermal ablation. Thermal ablation, we have the radiofrequency ablation, we have the laser ablation, we have the microwave ablation, and with the HIFU that we don't have in the United States. So the goal in the thermal ablation is to achieve a temperature of 60 to 100 degrees, so we can cause the denaturation of proteins, coagulation, bubbles, and destruction of the cells. So those are the treatments that we have in the United States. I want to repeat: we have the alcohol, we have the laser, we have the radiofrequency ablation, and the newly treatment that we have available in the United States is the microwave ablation. And again, those are the applications for different types of thyroid nodules.
Wonderful, thank you. And Dr. Mauri, I'd like to ask you, what procedures are currently available in Europe for the treatment of thyroid cancer?
So thank you very much for having me, and thank you for this question. As you know, we started this kind of treatments in Europe more than 20 years ago. We started with laser, that still is available, and then we moved on with the radiofrequency, and it is like 3-4 years now that we are also using microwaves. HIFU is present in Europe, but actually is not very frequently used. But all the other techniques are available, and of course, ethanol ablation is on the field for quite a long time. So at the present, we have almost all the technologies available.
And Dr. Tufano, tell us about the technologies available in the United States currently.
Yeah, and thank you, Jen, too, and to Gary Bloom, who for many years has provided resources for thyroid cancer patients here and all over the world. And so I want to give a big shout out to Gary, who's just absolutely wonderful and a dear friend. So yeah, in the United States, as Giovani just mentioned, we've been a little slower to adopt these technologies. And radiofrequency ablation has been around now probably for about 5 or 6 years in the mainstream, more and more to consider as an ablative therapy for thyroid nodules and select thyroid cancer. As Agustin already told us, microwave is starting to get a little bit of a foothold as people start to understand the energy and how to deliver it safely and where it has utility. Laser treatment has been available here in the United States as well, a little slower to catch on compared to RFA for some reasons, and not in particular because there's an advantage of one over the other, but comfort level and utility by the physician or the provider doing it. Those are the three main interventions, and I completely agree with Agustin that what we use ethanol for is really a cystic thyroid nodule, which is almost invariably, as long as it's purely cystic, a benign process, as long as it doesn't have any solid component. And that we would use the ablative thermal ablation therapies for anything more that has at least a solid component. Again, we can use it for cystic nodules, but if we use ethanol and we can use it cheaper, we have to consider the financial implications of such, which may not always be the case as ethanol has started to get more and more expensive for us here, especially in the United States. So we always have to think about all the considerations.
Definitely. And Dr. Tufano, why don't you outline the steps, the process of a physician to determine candidacy of a patient?
And in particular, Jen, are you asking about a thyroid cancer patient?
Yes.
Yeah. So, I mean, obviously, we're going to focus on that. And I think most of us in the United States who are doing interventional techniques such as radiofrequency ablation, thermal ablation techniques are very comfortable using that for benign nodules. I think what we have to consider is how do we start expanding the indications very safely and prudently to thyroid cancer. And I think the panelists will agree that there is a role that Giovani had already mentioned, that papillary microcancers are there and present, and they get detected. And despite the American Thyroid Association guidelines, the ETA, the European Thyroid Association guidelines, saying, please don't biopsy anything that's less than a centimeter, we know biopsies happen. We know a cancer diagnosis is rendered of differentiated thyroid cancer. And then the patient wants to know, and even the physician wants to know, what do we do next, right? So that's really challenging once you know there's a diagnosis of thyroid cancer. And I think I like the way Giovani had just mentioned it already, is that for these papillary microcancers, we have the ability to analyze them regarding their location on ultrasound. So each and every one of us does our own ultrasound and our own imaging evaluation to determine which ones would be a candidate for something called active surveillance, because we feel that most of these differentiated thyroid cancers, i.e. papillary thyroid cancers, especially in a safe zone, let's say that it's in the middle of the thyroid, normal thyroid tissue around it, it's probably not going to do much of anything over the next 10 years, as long as you also look at the lymph nodes and you see that there's no lymph node involvement, right? Pretty innocuous. But oftentimes what happens here in the United States is the diagnosis gets made, the patient runs to the surgeon, they get a total thyroidectomy, radioactive iodine, and there's a lot of downside to that. So I agree with Giovani that there is this value proposition for the patient, because when you tell somebody they have thyroid cancer, it's not enough to just say, oh yeah, don't worry about it. It's in a safe location. You could just watch it. The patient goes, what do you mean watch a cancer? Don't you have anything else? Well, we have surgery. What do you mean? That's too extreme. You just told me it's not going to do much. And then I may have to take thyroid hormone. What do you mean? Do I have a happy medium? And that happy medium is ablation. And I think that whatever you decide to do in whatever mechanism, whether it's laser in Agustin's hands or microwave or radio frequency, Giovani's hands, when you do it, you want to just do it safely and prudently. And those are the patients that are really the best candidates. And I would say as people are starting to think about this, getting involved in treating thyroid cancer and the patient's asking, hey, I have a small thyroid cancer, I don't feel comfortable watching it, it would be those that we already consider for active surveillance. They qualify for active surveillance, but they just don't want to watch a cancer. I think that's the perfect patient population. And we can talk about pushing the envelope a little bit in a little while, but I think that's the perfect patient population right now.
Perfect. And what about biopsies and tests and imaging? Are there any particular tests that are required to determine candidacy?
Are you asking me, or do you want to ask?
Yes. As far as like, I know with benign biopsies, there's usually 2 biopsies required. So what about with a thyroid cancer?
Well, papillary thyroid cancer typically is not that hard of a diagnosis to make on fine needle aspiration biopsy. We have a Bethesda categorization. Bethesda 5 is suspicious for thyroid cancer, usually differentiated thyroid cancer, which is papillary. The ultrasonographic features kind of clue you in on that too. Bethesda 6 is we're 99% sure it's papillary thyroid cancer. And of course, if we're relegating it to these small intrathyroidal thyroid cancers, we can feel pretty safe about using an ablative technology. So yeah, again, the bottom line is you need to do a very good ultrasound. You have to look at the thyroid and the central compartment and lateral compartment, because you can have a small intrathyroidal thyroid cancer perfectly, looking innocuous in the middle of the thyroid, but you could have lymph nodes. Now that's a different animal. So we got to rule that out. And if it's solely this little small cancer in the thyroid based on the biopsy suggestive of a papillary thyroid cancer, I really think that that's a very reasonable candidate. And the discussion should include the option for ablation for this candidate when you talk about all the options for treatment and management.
Thank you, Dr. Tufano. And I would love to know, Dr. Andrade, what is your opinion on how a patient could find a provider of these modalities here in the U.S.?
It's a very difficult question. So let me start saying that we need to categorize the doctors that are doing the thyroid ablation. A very good example are the surgeons. The surgeons have a high volume and a low volume doctors. When they do more than 100 per year, it's a high volume, and it was found that they have very little a percentage of complications in comparison with a doctor that does less than 25 thyroid surgeries a year. We don't have that in thyroid ablation. But just talking with my colleagues, we think that once you reach 30 thyroid ablations, maybe you have the expertise to do a thyroid ablation. And once you achieve the 50 procedures, then maybe you achieve a plateau that you're doing well with the thyroid ablations. Where to find the doctors? Right now is a lot of things that have to be the patient. The patient has to ask the doctors how many procedures you have performed. 3 months ago, a doctor was doing the application for a hospital, and one of the things that he was saying that he was expert in thyroid ablations, and they make me call the doctor, and he have done 12 thyroid ablations. So he, obviously, he's saying that, but those kind of things are not the best for the patients. More than to answer your question, I think that one of the future thing that NACID and NASAOI have to do is to do a certification where we can confirm that the doctor have done so many, 30 or 50, and the doctors can show us that the reductions, complications, and with that, maybe we can help the doctor better. I don't know what Giovani or Rav have anything to say about this.
Dr. Mauri, would you comment on in Europe the situation there?
Yeah, that's absolutely perfect. What I think all the experts in the field are now thinking, because at the beginning we were just very few working together, reaching experience. Now we are seeing a lot of physicians that want to start this kind of practice. but without a proper training and claiming that they are expert after 1 or 2 or just because they bought the machine. And what I'm trying to do I'm seeing that in Europe. I don't know in the United States, but it's something that is quite fashion now. And what we are trying to do with European society is exactly to establish a training program where physicians have to attend theory courses with certification, some hands-on on phantoms, and then some supervised and proctored procedures in their hospital. Because also saying that you have to do 50 procedures, if no one trained you, you can do 50 times the wrong things. I think it's that in surgery, every surgeon needs to have a good training, not only to do a lot of things. The other aspect is how to find a doctor. And this is something that is completely different in recent years, because in Europe, generally, the physician, the patient didn't have to find the doctor. The patient had his own doctor who had to send him to the proper one. Nowadays is the patient that is starting seeking for the proper physician. And here is where like the work of Jen is absolutely fantastic because we are lacking a good information for patient. I would love, and that's the plan for the next year, to have a website where all the physicians with a certain experience are listed. So the patient can find them easily in Europe at least, but it is quite a hard job even to find for me the physicians doing this kind of procedure. So I think there's a very big lack of knowledge in this field still that we have to fill.
I agree, Dr. Mauri. One of the things that we have done at Save Your Thyroid is just in an effort to let people know that there are many physicians now. It's amazing to be able to say that. In comparison to in 2019, when I was seeking this treatment, there were 2 available treatment centers, and now there are over 150 in the United States, which is a tremendous amount of growth. But at the same time, we don't necessarily know, as you were just discussing, the amount of practice that these physicians have in their skill set. So, on our website, saveyourthyroid.org, we do maintain lists of physicians in the US and across the globe who offer all the different thermal ablation procedures, but we do not, unfortunately, have the ability to vet all of them or to provide any sort of designation to their number of cases. So unfortunately, at this time, it is still up to the patient to determine that through these conversations, as you were saying, Dr. Andrade, asking them how many cases they've done, what is their experience level, and maybe even asking what sort of training they've participated in. So one thing we do hope to do in the future as a community for Save Your Thyroid is to provide resources for the primary care physicians to help educate them about these procedures, to help with referral patterns, as you were saying, Dr. Mauri, so that when they have a patient come to them and say, I don't want to have surgery, who can I be evaluated by to know about this? That provider can then say, oh, well, we do know about this. This is, as opposed to we're not aware of it. We don't know what it is. And I do know now someone who is offering it. So that's on the horizon. Stay tuned for that, everyone who is interested in that. So we already discussed who is a candidate, who's the ideal candidate, Dr. Tufano. Can you tell us who absolutely is not a candidate for thermal ablation? Maybe discuss the tumor size, location, genetics, etc.
Yeah, that's a great question, Jen. So I think that you have very expert panelists today. And if you were to really probe about, do we treat or can we in select situations think about treating a differentiated thyroid cancer that may be a little bit bigger than a centimeter and in a very fortunate location for the patient, and the patient is desperate to avoid a surgery and doesn't want to watch it, you probably will going to get a couple of yeses, right? But again, as Agustin and Giovani have mentioned, this is after many years of doing this and understanding realistically what we can and can't achieve. But I would say that for now, I want the general population to understand that we are sort of in the infancy of this technology and these types of treatments, and we're going to evolve these to probably wrestle with bigger tumors and maybe in more difficult locations. But I would say that anything that exhibits extrathyroidal extension, that it looks like it's extending outside the thyroid, especially in the backside of the thyroid, where it's going to be closer to the nerve that controls the vocal cord, where we may get the heat to the nerve and then hurt the nerve and your voice may be off, or we don't get enough energy there and we don't get rid of all the tumor. So what are we really doing in that circumstance? And anything bigger than, I would say, because we're wrestling with the American Thyroid Association guidelines, the next iteration, should we include up to 1.5 centimeters for active surveillance and possibly maybe ablation, right? I would say that anything bigger than 1 centimeter, 1.5 centimeters being at the margin, right? About that's as big as I would go, but it's still got to be in a very good, fortunate location for the patient. Anything else, I would say, and especially because of what Agustin and Giovani have already discussed, because there are so many providers with different levels of experience, I think it just opens up a Pandora's box and gets us into a difficult situation, and it may make an outcome even worse. And so I would say then, we need to keep it very strict for now until we see the technology and the training and all of that evolve for the greater good. I think we have to do that.
Definitely. And I would like to know also, Dr. Tufano, about is thermal ablation possibly an additional step that a patient could go through before surgery rather than just a replacement for it?
Well, I think if you're thinking about like making the nodule smaller to do a different type of surgery, or half of a surgery and half of the thyroid instead of all the thyroid, for example, there's really no evidence or data to support that kind of intervention. I think we would all want to intervene therapeutically, knowing that our ablation is going to hopefully get rid of the tumor. That would be the goal. Otherwise, why are we intervening? And why are we going to use 2 modalities when we could use 1, right? So I don't think that that's a wise way to use it. And so it's certainly has not been standard or practice. And so right now, I would say, no, we don't have a mechanism where we go, let's do an ablation so we can do maybe less of a surgery than we thought we were going to have to do initially or anything like that. And, we haven't talked about the role, though, of the ablative therapies in treating metastatic lymph nodes especially the patient who has had prior treatment, including total thyroidectomy, maybe even a neck dissection, central or lateral, radioactive iodine, yes or no, and they have a lymph node recurrence. And so we can use ablative therapies in selected situations there too. So we got the primary cancer inside the thyroid, and then we have the metastatic disease, and especially the patient who's already been treated, who comes back and has had a really extensive treatment, but has a single maybe node recurrence or persistence. And could we thinking about ablative procedure to control that area? Yeah, of course, if it's in the right location and there's the right physician doing it. Yeah, of course.
Thank you. And Dr. Mauri, do you have any comments on that as well? Since you're in a different field, you're an interventional radiologist, and maybe you have a different perspective.
Yeah, I have to totally agree with Dr. Tufano. And I mean, there are very, very limited cases, but let's say, quite extreme, where, for example, a patient has a thyroid cancer and just a single or a couple of distant metastases. So surgeons that can take care of the thyroid with the surgery, and we can ablate, for example, a couple of lung metastases and so on. But these are really, really let's say, unusual cases. So as a general rule, I do not see really a field where we have to work together for malignant tumors, at least.
Thank you. Okay, so now we're going to go into the process of the procedure, because it's a little different in each application, as Dr. Tufano just mentioned, for metastatic lymph nodes. But let's kind of maybe back up and talk a little bit about primary thyroid cancer. Dr. Andrade, kind of give us the process of the procedure for treating a primary thyroid cancer?
So as Ralph and Giovanni mentioned, the first thing that we have to do is to get the perfect patient for the procedure. So if I'm going to repeat what Ralph said, if the tumor is already invading the hyoid muscles, or I mean outside of the thyroid, or is invading the trachea, that's even though the nodule maybe is small, is not a good candidate. What if we have a Bethesda 5 or 6 and the patient have BRAF positive and TERT positive? I may be more inclined to do surgery rather than a thyroid ablation. But if I have the perfect patient, a nodule that is circumscribed and the inside of the thyroid and has 2 millimeters of normal thyroid tissue that I can work with, then that is a good candidate. Is too external, then of the thyroid, it's important to do some hydrodissection so there's no damage of vital structures. So once you have that patient and you put the hydrodissection and you use whatever you want to use, the radiofrequency ablation or the laser, usually with the radiofrequency ablation, I personally use the small tip, and then is safe to be performed. The other thing that I forgot to say is the size, and I couldn't agree more with Ralph. We choose the 1 centimeter, but we're now pushing the envelope to the 1.5. But I really don't think that we should have or do radiofrequency ablation to 1.7, 1.8 centimeter thyroid nodule, because it increases the risk that you may already have a microscopic metastasis into the lymph nodes, and you don't know. I don't know if that answered your question, Jen.
Yes, it did. And with the primary thyroid cancer, typically if particularly in radio frequency, is that typically you insert the probe and then you just ablate without having to do moving shot, or is there typically a moving shot involved?
There is some moving shot involved, because when you do that, you have to try to ablate 2 millimeters outside of the cancer. But the movement of the tip of the needle is not as when you do a normal radiofrequency ablation in a normal benign large thyroid nodule. So there is some moving, but is much less than the large benign thyroid nodules.
Thank you, Dr.
Can you describe what a moving shot is for those of us that don't know what that means?
I will say that Jen is very dangerous, Agustin. She's come to all our courses and she listens, so she asks these tough questions now, you know?
Indeed. So if you have a nodule over here, and this is my needle, and I do the radiofrequency ablation, you see the whitening of the tissue, and you see the impedance that is getting usually more than 200. Once I see that, and I see that that part of the nodule had been burned, I remove it, and I go upper, and then I repeat the same thing, and then I go this way, and so until I see that the whole nodule is burned. So that is the moving technique. And in laser, you have the pulling technique. So you burn the nodule. So you burn the nodule here, and once you achieve the 18 or 1200 joules, you pull a little bit, like a 1 centimeter, and you repeat the action, until the whole nodule is treated.
Thank you for explaining that. And I apologize if I didn't ask the question in a way that would make sense to the average layperson. Dr. Tufano, you're right. I do know a little bit more than the average patient.
Yeah.
So Dr. Tufano, you did talk a bit about metastatic lymph nodes already. is there a process that's different from treating the, as what Dr. Andrade was just saying, for the primary cancer with the metastatic lymph nodes? Because this is a patient at this point who has already had a thyroidectomy, correct?
More often than not, they've already had a thyroidectomy and they've had a radioactive iodine. They may have had even lymph node dissection, central or even central and lateral. And so it's very frustrating to have a recurrence or persistence. It's very anxiety inducing and provoking. And sometimes quite, people get very despondent to think that their cancer is persisting and coming back. So yeah, these patients, we have to consider what are the best alternatives. We have to have some equipoise here because, again, as Giovani has mentioned, we need people with expertise. So first, I want to make sure that there is a surgeon involved that has expertise and can talk about pros and cons of doing a surgical intervention. Let's say this patient had a very extensive lateral and central neck dissection, and there's one focus of recurrence. That may be a good patient for an ablative therapy, as opposed to somebody who maybe had a surgery where it wasn't so really complete. And there were a few lymph nodes left and a few areas that really were undissected that would be better served by completing and doing a very good, revision central or lateral neck dissection. But I think in the situation where a patient has had one recurrence in a well-dissected field, or maybe has had multiple surgeries, and this may be the only area, and with the expertise that's available, especially for differentiated thyroid cancer, we can talk about other cancers, but differentiated thyroid cancer, papillary thyroid cancer, as Giovani and Agustin just mentioned, it is very important, this concept of hydrodissection. So this is an advanced technique. Treating benign nodules is kind of easy. Then treating the primary cancer with select it carefully, a little bit harder. And then this is harder because where these recur are going to be in the central compartment. Higher is worse than lower because it's closer to the nerve insertion point. So you got to buffer that area with some dextrose, which is D5. It's sugar water, right? That's what we use to make sure the heat doesn't get out and about to hurt important structures. And in the lateral neck, the same, lower in the lateral neck toward level 4, behind the internal jugular vein and carotid and vagus, more problematic than something sitting lateral to the internal jugular vein, a little more superficial, which we feel much more comfortable treating. So I tell people a lot that this is like real estate. Location, location, location. You got to understand the location. Your imaging is so essential. And then the expertise, because you need somebody like a Giovani or Agustin to get that hydrodissection, separate it nicely. It's in a nice aqueous barrier, and then we can really target it and ablate it more comfortably.
Thank you. And Dr. Mauri, talk about treating distant metastases. This was something we discussed in our recent podcast episode, which was something I was not even aware of. So tell us about that, please.
Yes. Let me just briefly comment on the two previous questions, because I want to point out, as Ralph was saying, that it's important to have a good surgeons, but also good interventional radiologists, or what we do is to have a good multidisciplinary team.
Right.
In our hospital, whatever kind of physicians you see, the endocrinologists, the surgeons, or the interventional radiologists, first, we are providing all the necessary information about everything. And very often we call colleagues or have like multidisciplinary meeting with the patient to explain with the surgeon, with the people that are doing the ablation. So there is absolutely no competition among physicians, but all we are there for the patient. Because too often it seems like, okay, Dr. Mauri, I came to you, but don't tell the surgeon that I'm here. We have to work all together for the patient. This is one of the most important things, I think. And this is also about metastasis, because as soon as I got into the multidisciplinary team of the head and neck cancer, I started also seeing patients that were sent for chemo or radiation therapy without even knowing that there were other possibilities. Just think how many cases we treat with vertebral metastasis with ablation and cementoplasty, which is sometimes more effective than radiation therapy. not only from thyroid cancer, but we can treat lung metastasis, liver metastasis, bone metastasis, of course, in very carefully selected patients. But still is something that is on the field and that should be known by surgeons, endocrinologists, and the people involved in this field, because we can provide, again, very, very selected cases, but excellent results.
Thank you, Dr. Mauri.
If I may, just one thing,
Of course.
I well remember the first patient that came to us and where we started doing this kind of treatment was a patient with a lateral neck metastasis that was sent by the surgeon. And it was the first time in my experience for a surgeon to send a patient to us saying, I do not want to do the surgery. It's very unusual because there was quite strong competition. And she had one single metastasis after 3 neck dissections and really didn't want to have any. We treated her, and after 5 years, another lymph node. And now I saw her 6 months ago, and it was in 2012, and she absolutely happy with just 2 ablation. So that can be a very good solution for our patients.
That's amazing. Thank you for sharing that, Dr. Mauri. And Dr. Andrade, let's talk a little bit about inoperable thyroid cancer.
Inoperable thyroid cancer. So what is an inoperable thyroid cancer? This is probably related to the poster that was presented in the ATA of a 92-year-old female that have a severe coronary artery disease, and it was not operable, and the patient was having symptoms. That patient had BRAF and TER positive, which is a gene mutation that gives us a bad prognosis. In those patients, to do radiofrequency ablation to improve the quality of life of the patient is something that could be achievable. But I want the public to understand that this is not to cure the patient, it's palliation, that is different. So the intention is to improve the quality of life of the patient. In those patients, I have not too many. I have like 3 or 4 patients that we have treated with radiofrequency ablation and or laser, and we have been able to improve the quality of life. There's another set of patients that goes along with Giovani and Ralph. I have 2 patients that were sent by surgeons because the benign tumor was causing tracheal obstruction. They couldn't intubate the patient for the surgery. So in those 2 patients, we did radiofrequency ablation. The trachea was open, and then the patient was able to have full surgery. So that is something, the benefit that we can achieve with thyroid ablation as well.
Wonderful. Thank you. Okay, now we're going to switch gears a little bit and talk about insurance coverage for these non-surgical treatment options. Dr. Mauri, I'd like to hear from you first for what is the situation with that in Europe?
Yes, in Europe, we have a completely different healthcare system. And particularly in Italy, everything is provided to patients for free from the public healthcare systems. Let's say more than 90% of patients are cured in this way. So the very, very big work that we had to do has been to provide all the information to the national healthcare system to include this kind of treatments into the one that are actually recognized as reimbursed by the national healthcare system. So at the moment in Italy and let's say in a lot of countries in Europe, this is provided by the national healthcare systems for free to patients. Of course, being that also the insurance is I have a complete coverage of a treatment that is also allowed for the public healthcare system. So this is not an issue now in Europe.
And in contrast with that, Dr. Tufano, would you tell us about the situation here in the US?
Yeah, it's a little bit more complex.
Right.
just to, say the least. So anyway, for benign nodules, interestingly enough, there's enough evidence-based data that I think a CPT code is imminent. So we're really excited about that. And, for the most part, the payers and providers, we see Medicare starting to come around even before this, where they're covering a fair number of the procedures for benign nodules, and also very rarely the commercial payers. But then once the CPT code comes out, I think that'll be a whole new ballgame. For thyroid cancer, it is sort of, again, not as common, and we don't have as much data to drive it. And of course, the US wants to see a lot of US data before a CPT code would be particularly applied. And so we have a little bit more of a problem with that. We've seen some situations where in a palliative situation, especially with our interventional radiologist doing it, there has been some coverage. But for therapeutic intent for a primary, it has been hit or miss. So it's a little bit different here in the United States. And Agustin can talk about his experience, because I think each of us has a little bit of a different experience depending on where we are regionally too in the United States.
Dr. Andrade, would you like to comment?
So in Florida, Ralph, you're also in Florida.
Yeah.
They're not, Medicare are not paying me for the radiofrequency ablation. It's very hard. They pay for laser, but now the private insurance are start to pay a little bit more. But is not universal. They had to apply it and resubmit. That is a pain in the neck. But I think, as Ralph says, that pretty soon we're going to have a code for RFA, and it's going to be everybody's life easier.
I agree. And I'll just comment on our experience within the Save Your Thyroid community, which is currently over 8,000 patients. We're seeing a huge disparity in treatment being covered, whether it's benign cancer, and depending upon even who the provider is, if they are in a hospital versus in private practice, or what their medical specialty is. It's all across the board variable, and not really any patterns have emerged yet. We have seen patients receive coverage by Medicare. We have seen insurance cover, and we've seen insurance deny multiple times. We have seen patients submit appeals, and after the third or fourth try, get reimbursement. The general consensus is that patients are very eager to pursue non-surgical techniques and preserve their thyroid gland. And so many of them, if they are financially able, they will pursue these even on a cash pay basis, and are even willing to travel to do so as well. So, I'm still encouraged, even though, we don't have the same situation as Dr. Mauri was mentioning in the US, that patients are eager enough to pursue these procedures that they will pay for them out of pocket. And ultimately, what we find is that many patients they consider the long-term expense of losing their thyroid gland and being on medication and the costs associated with surgery to be not nearly as significant as the out-of-pocket initial cost of a procedure like RFA or laser. So our last question before we move on to the Q&A, Dr. Andrade, let's talk a little about the importance of continuous follow-up after thermal ablation treatment.
So usually after the radiofrequency ablation or the thermal ablation, we see the patient 3 months later. And then after that, we see it sometimes 6 months later and a year, and after that, every year. But over here, there is an opening to several situations, because if you're treating a toxic nodule, you have to see the patient more frequently, because you're also tapering the methimazole. In some patients, they are taking. Some patients they need to stop the methimazole at all. There is depending on the size of the nodule, the nodule is bigger, is less chances that the nodule is going to be cured with thyroid ablation versus if the nodule is small, there is very possible that that toxic nodule is going to be cured or normalization of the TSH, because there's two things. One is there is very likely that the tumor is going to be smaller with the thyroid ablation, but it's a different thing, the TSH. So that is important. So for those reasons need to be followed. The other thing is, generally speaking, when we finish the radiofrequency ablation, that's the end of any complication. I mean, the patient may have a bruise, or even if the patient have changes in the voice, usually that is temporal. Within 3 months, the patient recovered the voice. But there is a particular complication that the patient, they need to know is the thyroid nodule rupture. That is 1% of the cases. And it's important that the patients know that if the patient have a rupture of the nodule, it's not that the treatment has been not successful. And not every rupture of the nodule needs surgery. They can be treated with non-steroidal anti-inflammatory medication. Sometimes the doctors, they use antibiotics for 2-3 weeks. And the only problem that is it lasts for a month. The problem sometimes more than a month, but it gets better. In few occasions, when you have that complication, you have to remove some of the necrosis that is inside of the thyroid by regular aspiration with the ultrasound. And in those cases that I have aspirated that fluid, the patients improve immediately after that aspiration. But yes, that's what I do for follow-up of the patient after a thyroid ablation.
Thank you. Okay, we're going to move on to...
May I just very briefly comment on that? That is for benign thyroid nodule. Nodular rupture is not for thyroid cancer. I mean, never occurred to me. So just for patient to know, is for quite big nodules. And it's very important that the patient undergo follow-up in centers where they have knowledge about thermal ablations, because the appearance of the treated nodule can seem like a tumor. I received some patient that underwent ultrasound outside my hospital, coming back saying, okay, my tumor is very larger than it was before. So follow-up is absolutely crucial, but again, it requires expert people. I'm sorry for adding that.
No, I appreciate you inserting that.
Thank you.
And I think that's important to mention, Dr. Mauri, because oftentimes we do have patients in Save Your Thyroid who will see someone locally who is not familiar with thermal ablation for their follow-up because they traveled a long distance for their treatment, and their local follow-up physicians are not aware of what has been done and don't understand what they're viewing on ultrasound. So I think that is very important to mention. Thank you for bringing that up.
It is very easy to send the images. I always provide my email and tell the patient, before having any fear, just send me the images and we can discuss that online.
Absolutely. Awesome. Okay, well, now we're going to move on to the questions from the audience. So the first question is there any role for these non-surgical interventions for lateral neck lymph node mets from medullary thyroid cancer? This patient had a total thyroidectomy and a central neck dissection a few years ago. And I think we alluded to that some, but Dr. Tufano, would you touch on that as well?
Yeah, happy to. I think you can consider an ablative therapy in a similar situation where a patient may have an isolated recurrence or persistence of disease after formal treatment, which is usually for medullary thyroid cancer surgery, right? So surgery, it's a primary surgical disease. We do have some novel chemotherapies that we may, and we're trialing in a neoadjuvant way, meaning that we would give a chemotherapy up front to reduce the volume of disease and maybe an aggressive medullary, and then maybe that makes the surgery easier, but that's in trial, so we don't have any evidence to say that's what we should be doing. But in a patient who has had, let's say, just like we've discussed so far, that surgery and a couple of maybe neck dissections, this is an isolated recurrence, the calcitonin level, is not remarkably high, and you just want to achieve a little, local control, I think we have to consider ablation as an option, and we should be including that in the discussion. Absolutely.
Thank you. The next question, I would just like to let the asker of this question know, I think your question is a bit too specific for this forum. So if you would like to reach out to me at saveyourthyroid@gmail.com, I can talk with you more specifically about that outside of this meeting. And then we've got a question about using thermal ablation on a 9-millimeter lymph node that is near the carotid artery and vein. This patient had papillary thyroid cancer, a total thyroidectomy, and radioactive iodine, lateral neck dissection, and PET scan to show that this lymph node is cancerous.
Yes, if I may answer, that's exactly the kind of patient where I started from. Of course, it should be visible on ultrasound, and a good hydrodissection is mandatory, but 9-millimeter lymph node, also if it is close to the carotid artery, can be treated with ablation. Of course, each patient should be carefully evaluated before a confirmation of the feasibility, but it seems absolutely a good candidate.
And Dr. Mauri, I think this question also would be good for you. This patient has medullary tumors on the liver. What is the size that these need to be, and the pros and cons of this procedure?
Yeah, we are treating a different kind of metastasis, and generally the rule is that the results are very good, let's say comparable to surgery, up to 3 centimeters. And we are treating up to 5 metastases in the liver, up to 3 centimeters, with comparable results as surgical resection. Now, of course, each case should be evaluated because there are some anatomical situations, for example, lesion very close to the bile ducts that cannot be treated by thermal ablation. That's another, of course, field where a careful analysis from an expert is mandatory.
So what would you say is a good size, or is it variable per individual?
Yes. It is generally speaking up to 3 centimeters and up to 5 metastases. That's the general rule.
Thank you. Okay. What happens to a cancerous nodule once it is ablated? If it is absorbed by your body, can it cause any further problems at that point? This is a great question.
Yeah, quick answer, no. No problem related to absorption of the tumor. I don't know if anyone else want to comment. This is a very long history. We are treating with ablation tumors in the liver. The first experience were in the late 80s. So about results of cells after ablation, we have a very large experience, and there's no problem with the dead tumoral cells into the body.
And the immune system pretty much just eats them up and disposes of them.
Yes,
Yeah.
even might occur quite rarely that the destroyed cell stimulate the immune system, and we achieve some abscopal effect. We have seen patients treated in the liver that after ablation responded in the lung, because the dead cells into the body acted as cells that were recognized by the immunological system, and so also distant results were present. There are some trials by combination of ablation and immunological drugs to improve the effect of the immunogenic effect of the combination.
Interesting. Very interesting. Okay, we are running low on time, so I'm going to take one more question and then close out the session. So for a patient doing active surveillance for micropapillary cancer for many years with everything remaining stable, what advantage would there be to pursue an ablation? What are the pros and cons of continuing with active surveillance versus ablation?
I'm happy to take that one. These are great questions, and anytime a patient has a question, it's a great question, right? That's, they make us think a little bit about their perspective and what's in their mind. So, it's great that we have all these questions. if you are comfortable and you can sleep at night and you don't worry about when the next ultrasound is going to be, and you check your calendar and you go, oh, I got my ultrasound next week to see if that thing has changed or not. But yeah, I wasn't worrying about it. Then why do anything about it? But if it bothers you and you're tired of watching it and you want some maybe relief up here, and your family's bugging you a little bit, do something. Now you may be able to do something not as extreme as surgery. And if it just makes you uncomfortable, then there may be some value. But to each and every patient, it's going to be different, right? And so that's the important thing, is that we treat the patient, we understand the patient and their patient perspective. Because if this patient is entirely comfortable and it's been stable and there's nothing of concern and they're really relaxed about it, what are we doing? What are we achieving in that in that way? So, I think that's the careful consideration. Don't let anybody twist the arm of the patient in that. We have to have equipoise and be really equally discussing everything and all the options available. Some
Thank you
people
so
may
much.
not be comfortable and they want something done, even from the beginning of the diagnosis. Some patients may just want a surgery because Aunt Millie had something they watched and it turned out to be bad. And I don't care, Dr. Tufano, I want you to take my whole thyroid out. And you're like, you don't need it, but I want it. What am I going to do? Right. So we have to have this discussion. There's value to them. They understand the ramifications and what the end result is. Are you understanding? I understand, Dr. Tufano. It's my body. This is what I want. Okay. They're very respectful of that.
Thank you so much for your comment on that, Dr. Tufano. Unfortunately, we are out of time. So if your question was not answered, please send it to me via email, saveyourthyroid@gmail.com. So with that, we'll need to say goodbye, but thank you so much for joining us. Thank you to all of our speakers, and please enjoy the remainder of the conference.
Thank you very much.
Take care.
Yeah,
Thanks
thank you
from
very
Denver.
much.
Thank you. Thanks from Denver.
Enjoyed it very much. Thank you.
Thank you. Take care.